Hello, my name is David Lee, and I'm one of the co-founders of Intervention Services and Coaching. And today, what we're going to talk about is about treatment and levels of care and rehabs, because it's a part of any intervention. When we talk to families about our model of intervention, we go through basically a series of stages. Right, stage one for us is all the prep work, all the letters, who's going to be there, what day is it going to be, and then also it's where we choose treatment. We try to find the appropriate treatment for the client. And stage two is the intervention itself, the face to face. Stage three, they're either in treatment, we're collaborating with the family, and or we're in kind of a boundary stage. And then stage four, theoretically, is when they're stepping from a residential treatment program back home. And in some cases, they'll go from residential to outpatient or IOP or sober living or therapy, whatever it is, right? And a lot of times people don't really know what each of these things is and where people fit. And for us, stage five is we can all take a breath and relax. We're no longer as necessary, and hopefully the big umbrella of treatment is no longer as necessary. And so picking treatment, one of the most common questions we get all the time from families is what's the best, right? What did it for you, David? Which one's the best? I heard this program down the road's pretty good. I heard this other program down the road not so good. I've heard some things about outpatient. I've heard that outpatient isn't very good. And I've heard that, this place is. And should we send them on a plane? Should we keep them local? And so hopefully I'm going to be able to address the kaleidoscope, right, of all this different stuff, the uncertainty, if you will, and hopefully give you a little bit more insight into how treatment and recovery work, especially in regards to interventions. And so what a lot of people don't understand is that there are levels of care, and they exist for a reason. And most importantly, the addict, right, or mentally unique or whatever, mentally struggling, doesn't get to pick where they fit. And so this is important because, a lot of times I'll talk to families and they'll say, well, he doesn't want to go to residential. He said he'll only go to outpatient. He says, or she says, they say, they'll only do X, Y, and Z, as if they're the decision maker. In actuality, there is a kind of an almost a science, if you will, that was developed by the American Society of Addiction Medicine. We refer to it as ASAM, ASAM. And what it is a series of kind of criteria that we look at, we being treatment providers, and in 6 different categories, and based upon where people are in these, we make decisions that, hey, you fit here, or you fit here, or you fit here, or you fit here. And basically, in a nutshell, there are, for all intents and purposes, there's technically 5 levels of care within addiction. And so one could argue there's 6, right? 6 is 0. There's no level of care over here. There's like the 0 level of care. So 0.0, nothing. And it doesn't necessarily mean that I'm getting loaded, in my story. It just means that I don't necessarily have an umbrella, a clinical umbrella, no interconnectedness. I don't maybe necessarily have a therapist. So that the next lowest level of care is 0.5, right? And it's the lowest possible level of care. Perhaps a therapist, it's very minimal. And the reason it's very minimal is because I don't need a lot, right, in this story. For a person to fit or meet the requirements of the lowest level of care, you have to have a few things that are going on in various areas. And I'll go over what these areas are in a bit. The next level of care is a 1.0. That's where we start to put a toe into maybe just outpatient, right? A couple days a week, couple hours a week, lowest level of outpatient. A lot of people don't realize there's actually 3 or more levels of outpatient alone. There's not just outpatient. Outpatient has little levels, right? And so outpatient itself is just usually a couple days a week, a couple hours. Maybe I go on Tuesdays and Thursdays, and it's for a client who's highly motivated. You know, the risk of relapse is pretty low. In other words, all I need is that. I just need a little bit of extra. 1.0 level of care. We start getting into the 2s, right? The 2s are a higher level of outpatient. What's higher level of outpatient? IOP, also referred to as intensive outpatient, which could be 3 days a week, could be 4 days a week, could be 5 days a week. And so, you know, I'm going in every night for 2-3 hours. That's intensive outpatient. It's the next level up, right? And then the highest level of outpatient, the highest possible level, the most outpatient you can do is what we call PHP, or Partial Hospitalization Program. And there's kind of a little bit of a layer above that, which kind of came about beginning maybe over a decade ago. And what it was PHP with housing. And so what it was is technically an outpatient program where you go into outpatient at a PHP level, which is every day, like 4 or 5 hours a day. But because they added a house down the road that you live in, and it's managed and overseen to reduce the risk of relapse. And it's referred to as PHP with housing. For a time, it was called the Florida model or the California model because it was pretty common in those 2 states, right? So a lot of times when you're looking on the internet and you see or you talk to somebody and they're like, oh, well, they live in a big house by themselves. They make their own meals, you know, and then they go into the center. That's what's referred to as PHP with housing. It's actually technically an outpatient program. Those are the 2s. The 3s, the 3.0s level of care, is what's referred to as residential or a low level of inpatient. And residential is you kind of stay there, live there, you're on the grounds, you're not really leaving at all. You're kind of there. There's no going in and out of the program down the road. You are down the road. You're already there, right? And so residential, in many cases, you're sleeping there, your clinical offices are in the same place. There may be a doctor who comes in during the day. Rarely will you see a doctor 24/7. In many cases, you'll have a nurse that's there either part of the time or 24/7 nursing. And so it's called a residential. It's what a lot of people think of as rehab. Now we get to the 4. And the 4 is medically managed, medically supervised inpatient. 4.0 is the highest possible level of care that you can get to. Hospitals, for example, in certain stages in someone's recovery, you may temporarily end up there. And I'll give you 2 common examples. The first is if I make a suicide threat. Right? I'm going to make a suicide threat right now. I'm now kind of a danger to myself. I end up temporarily in the highest level of care. And not necessarily in the addiction highest level, but it's in the highest level of care, right? Medically managed, medically supervisors, 24 hours of nurses, doctors, etc. I'm almost always in a hospital type of setting. Another common thing is alcohol or high benzo intoxication, when there's a super high risk of seizures, right? There are many traditional treatment centers or residential rehabs that are not a 4.0. They're a 3.0. The majority of residential treatment centers across the country are in the threes. They're residential rehabs. They are not the highest possible level of care. And so what can happen is if I show up and I'm a high risk for seizure, they'll do a quick evaluation and they'll say, oh my goodness, we got to send you down the road to that place, which is a 4.0. A 4.0 level of care, high risk of seizures, perhaps a higher level of acuity or danger, that we need a little bit of a medical umbrella on top of them. And so all these levels of care that I've mentioned, I as the addict, I as the client, don't necessarily get to decide, right? And so if we look at this not through the lens of addiction, let's just look at it through regular medical stuff. Let's say I have like a light chest cold. I don't get to knock on the door of the local hospital and say, hey, I have a chest cold, I want to check in here for 28 days. It's the wrong level of care, right? It would actually end up possibly being harmful for the patient to enter into the wrong level of care. It's called iatrogenic harm. It's when the treatment can sometimes have a detrimental effect. In other words, if I put somebody into too high of a level of care for where they belong, it can have a blowback. I'll give you an example in the addiction arena. Let's say I wake up today and I discover that my 18-year-old son smoked marijuana one time. And I'm fundamentally against marijuana. I think it's horrific. And just to be safe, I'm going to put him in a 1-year lockdown program because he smoked marijuana one time. It's the wrong level of care. It's way too high of a level of care for where that client, my son, belongs. And I promise you that if you do that, it'll have a counter effect. In a situation where somebody maybe just smoked marijuana one time, there's some low-level stuff, perhaps they belong in a lower level of care in the beginning stages. And then what will happen is the client will either improve or they won't, or they'll get a little worse. And then we slowly raise the levels of care. And so another example of the wrong level of care is if I break my leg today and I knock on the door, I roll in or whatever, I limp into the local hospital and I'm like, hey, broke my leg. And they're like, oh my goodness, we got to get you into surgery. And I was like, surgery? I'm not checking in here. I don't like hospitals. I'm willing to go to physical therapy once a week, but I am definitely not willing to get checked into this hospital. I don't get to choose that. And if I did skip the highest level of care surgery, go straight to physical therapy, it would be detrimental to me, right? Wrong level of care. Wrong treatment, wrong level of care. And so on the same token, we've had a large number of clients that are full-blown alcoholic, drinking every day, high seizure risk, full-blown heroin addicts, using every day. And when presented with treatment, they're like, I'm never going to go to a rehab. They're like jail. But I will consider going to that outpatient down the road. Well, wrong level of care. Absolutely the wrong level of care. And why? There's a few reasons why, and we're going to get into that in a second when we get into the criteria or the dimensions that are used to decide where somebody fits. So the most important thing that I want you to understand is that the client, the patient, if you will, has less agency or less votes than you realize in terms of where they fit. And so that's kind of it. And I will say, jumping a little bit ahead, that if the client is extremely resistant to changing to the degree that you need to hire an intervention, it almost always means that they belong in a residential setting, not an outpatient setting. A lot of people will say that. Do you guys ever do interventions and get people in outpatient? Extremely rare. And the reason it's extremely rare is because it's the wrong level of care. Their readiness to change, if you will, is so low that outpatient will actually have either no effect or a worse effect. And people are like, how in the heck could outpatient have a worse effect? Well, I'll get into that in a second. And so it's important to really, really understand that how these levels of care interact fall into what's called a continuum of care. In a perfect world, treatment and recovery is a dynamic river. It's a changing river. What I, for example, need today is way different than what I needed at the beginning of my journey. For most people, the beginning of their journey starts with something like detox, right? Which is a level 3s, possibly 4.0 level of care. Well, you don't stay in a 3. You don't stay in residential forever. There are parents that would give anything to do that. I have parents all the time. They're like, is there a 1-year place? A 1-year place, thinking that if you lock somebody away for a year, it's going to heal them for a year. Yes and no. At minimum, what you'll do is prevent them, possibly, from using, because they're kind of on an island for a year. But there can end up being a bell curve of success. They'll get better, they'll flatline because they're in kind of a closed system, and then they'll actually, in some cases, start to get sicker. They'll start to lose the coping mechanisms of dealing with addiction and emotions and dysregulation and stuff like that on the outside. They grow highly dependent on the closed system, the microcosm. And if they could stay in the microcosm forever, it might be okay. But in many cases, you'll run into clients that do really well in this system and not so well outside, you know? Another danger that families run into is they look at it from a very binary approach, which is they go to rehab or they come home. Rehab, home. Rehab, home. Like as if there's only 2 levels of care, right? Home and that residential rehab, when in reality there's a variety of. If we could design over a year the perfect, highest possible success rate, if you will, program of recovery, it would be the highest level of care on the front end, right? Residential, with continual step downs, down to perhaps outpatient, PHP or IOP, down to outpatient, down to therapy, support groups, perhaps structured sober living somewhere in the middle. And slowly over time, we change small percentages of that. And so why? Why in the heck would we do such a long-term approach? Well, it's important to kind of understand, and this is just kind of my interpretation. You know, I've been into a lot of treatment programs myself. I have worked in many. We have referred thousands of clients into treatment. And so this is just kind of my interpretation of a way to look at treatment. People mistakenly assume that in a rehab, a residential rehab, the client is doing the most work. They're in there for 28 days, they're doing the most work. And the client will argue that, right? He went away for 28 days, right? He was in all these groups all day long. He was in 8 hours of groups. He was doing all this stuff, right? And I'm here to tell you, that's a flawed way of looking at it. In actuality, it's the opposite. What is the opposite? Why is it the opposite? Why is it that if David goes to a 28-day program, a residential or an inpatient, I'm actually doing less quote-unquote recovery than if I were technically an outpatient? That doesn't make any sense. I look at the schedule. Schedules, I'm in these stupid groups all day long. I'm doing all this work. I just got done doing 6 hours ago. I've been in therapy all day. It's a flawed misunderstanding of how treatment kind of works. The highest level of care, residential or treatment, or residential or inpatient, means that the provider is doing 90% of the heavy lifting for the client. And I define the heavy lifting as recovery. I am addicted to avoiding uncomfortable feelings, things, and situations as an addict. My emotional muscles have gotten extremely weak. And the only way for me to get stronger is to do the heavy lifting, to do some uncomfortable things, right? To intentionally do some uncomfortable things. And I am resistant to uncomfortable solutions. I am resistant to uncomfortable things. And so therefore, I belong in a residential setting, and they are going to do most of it for me. They're going to do most of it for me. What are you talking about? Well, they're going to house me. They're going to prevent drugs from entering into this building, right? They're going to put a little wall around it. They're going to feed me. They're going to bring the therapist to me, almost to my door. Like literally, it's like down the hall. They're going to bring the process group, facilitated by a professional, down the hall. They're going to bring the medical provider, the doctor, and the psychiatrist to me. They're going to control and manage and dispense my medications, right? So they're doing 90% of it for me. And I mistakenly think that I'm doing it all. And I'm going to give you kind of a little bit of an analogy to help you to kind of understand this. So let's put this in terms of physical fitness, because physical fitness and mental and emotional fitness are similar, believe it or not. So let's say in my story, I'm exceptionally overweight. Let's say I'm several hundred pounds right now, and as a result, I have some symptoms, right? For me, a 10-pound weight feels like a 100-pound weight because I don't work out. I'm so exhausted. I'm so out of shape. If I were to walk around the block, I'd be out of breath. It would feel like a mile. And so I have symptoms related to my dysfunction, right? And so let's say I make a commitment that I'm going to go away to a 2-week like wellness fitness kind of place, right? And I do. And I show up and I'm there, and they put a wall around it and no cookies can come in. And they make nutritional and healthier food based on, I learn about nutrition. I learn about calories and carbohydrates and a balance of a meal. I also learn a little bit about the body, the effects of certain things. I get blood work up. I get encouraged to do like some light fitness, because I'm pretty overweight. So it's not like I'm going to be working out 6 hours a day, but just some light fitness, maybe a half an hour a day, some walks. And so what's going to happen in a week or two is I'm actually going to start to get better a little bit. I'm going to look at the scale, and I've already lost 10 pounds. I might even be in better shape now than I have been in years. And I falsely think that I have done it. That I now have the skills and the knowledge in order to be a physically fit person, right? And what a common red flag that you will hear with your loved one a lot is this phrase, I know what to do. I'm going to tell you right now, every human being on the planet knows how to lose 500 pounds. 100 pounds, knows how to lose 30 pounds. Knowledge is not the same as doing, right? The I know what to do is a trap. And so in my story, I call my friends up and I'm like, yeah, getting ready to go. I'm really grateful I came here. And they're like, cool, we're really glad you're going to come home. And we really want you to join us at this workout, this gym we're a member of. We're going to pick you up. We're going to take you to the gym every Monday, Tuesday, Wednesday. And I say, gym? I just got done working out for like 2 straight weeks. Gym? I don't need that, I'm good. I think that I know what to do. I think because I took some educational classes on nutrition that I have the wherewithal to balance my meal. I think even though I've never actually cooked a healthy meal in my life, it was cooked for me in this rehab, that I'm just going to do that on my own at home. And so what will happen historically is I will get home and I will begin to redesign the treatment plan that was suggested to me. Do this, do this, do this. Get a personal trainer, go to this gyms, join a support group, join this, join that, go to Overeaters Anonymous, perhaps do some meal planning, weight loss things, meals. Everything that they suggested that gives me anxiety, Gives me a little discomfort, I will nix. Don't like it. Don't like working out. Okay, well, how about CrossFit? I don't like CrossFit. My brother does CrossFit. Okay, how about yoga? Whoa, yoga. It's just super uncomfortable. I don't look great in spandex anyway, so I'm just not going to do it. And, okay, how about sauna? Too hot. Okay, how about a personal trainer? Would you benefit? Ooh, I don't really, nah, I don't want some guy tell me what to do. Okay, how about support groups? Going to overeat? No, like all they do is talk about eating and food. Triggers me right up. That's all I need. You know what? I now know. I know how I fell off the wagon years ago, and I'm just going to be different. And so that right there is a common thing that happens, right? Is that I falsely think that I did all the work. Ironically, a residential treatment center, the client is only doing 10% of the actual recovery, the heavy lifting. The treatment center does 90%. And in a perfect world, how it works is what we do is treatment holds all the batons. We do all the work for you in the beginning. And then as we step down in levels of care, we pass some of the batons to you. In other words, like you come home, but instead of directly at home, you live in a structured sober living, where we kind of try to manage your recovery. And one of the requirements are you got to go to these support group meetings, and you got to go to therapy, and you got to do some things, right? And we drug test you. So in other words, although you have some more freedom than you did in the residential, what happens is you don't have fully, we've dropped it down 10%. And then eventually 10% more and 10% more until you get eventually to a place like I'm at, where I'm pretty much 100% in charge of my recovery. You know, I don't have really an overseer. You know, I have an oversight. I don't have any of that stuff. And now, granted, I have some accountability. I'm in some support groups. I've got, some friends and family members. But realistically, there's no more treatment plan necessarily that's being determined by an outside source. I'm internally motivated. My motivation to change is fully internal and a little bit external. And so as a result of that, I'm in the river of recovery on my own, and I can pretty much be in the lowest possible level of care. The number of clients that I have sat across from that belong in the highest level of care and argue that they belong in the lowest level of care is like 80% of them. It's one of the challenges on every single intervention. I will argue that every intervention is really a chess match between two sides, right? And on our side, we are going to design the highest possible success rate plan, right? Going out months. That's what we're going to talk about on the intervention itself. The client will historically redesign every aspect of that from the beginning till the end, every step of the way, to a program not based on success, but based on comfort. I have seen clients convince their family that no, they don't need residential, they don't even need outpatient. All they need is to go to one AA meeting a week. I have seen clients go from, yes, I'm in rehab residential, and yeah, they're recommending that I stay another month, but I don't think I need that. And yeah, I know they're recommending a structured sober living, but I know what I need to do. I need to come home, and I promise I'll go to meetings. And even though it is suggested, for example, in like a traditional support group setting, that you go to like a meeting a day for 90 days, right? 90 meetings in 90 days, or 90, like therapy, like it needs to be a daily thing for 90 days, right? And they'll redesign that daily thing into a once a week within weeks. And so it's really, really common as a part of the pathology of addiction to push back on anything that is uncomfortable and to redesign the treatment, to fire all the professionals and instead to be in charge myself. And the false thing about me being an addict is I think I'm in charge. I think my intellectual brain is what's designing everything, and nothing could be further from the truth. In reality, the person that is really redesigning any treatment is my emotional brain. One could argue it's the emotionally immature. I don't want to do anything uncomfortable, emotionally entitled 10-year-old version of me, the pouting, I don't want to do it if I don't have to. That's the person who's redesigning the treatment plan that was designed by the professionals. And I'm so good at it that you think I'm making a rational decision. Yeah, I don't like them stupid meetings. All I do is talk about drinking. Oh, yeah, that kind of makes sense. Yeah, I don't really think I need to go to them stupid little, sober living houses. That's for people that are, don't have a job. I don't think I need to go to therapy. What am I talking about my feelings all day long? Trauma work? No, I don't think I need. They wanted to give me naltrexone to minimize the cravings for alcohol. I don't want to be taking any stupid medications. Yeah, I heard about this Sober Link. Yeah, they've tried to get me to take this Sober Link, which is a stupid device I breathe into. I don't get run around with some stupid device. I don't need that. Interlock device? You mean the breathalyzer thing on my car? I don't need. What am I get? I can't be doing that when I'm driving around blowing into. If I'm gonna stay sober, I'm gonna do it. I don't need any of that stuff. Trying to keep. I'm either all. You don't know me. I'm all in. When I make a decision, when I decide to do something, I'll do it. So I will redesign your treatment plan at every step of the game. For us, an intervention is not just a singular day. It's a collaboration over months, right? And in the beginning, we're designing a treatment path. In a perfect world, we're designing more than just simply a month. And we're plopping it in front of somebody. In some cases we don't, and we do it in pieces. But realistically, at every change in the level of care, there is a breaking point, a moment in there's bridges and blocks, right? A bridge is a smooth segue through the levels of care. I go from inpatient to residential, segue, and I follow all the suggestions. Residential, I go home to outpatient. They suggest that I go to these meetings and I get a therapist and I take naltrexone and I do it. It's a bridge. But more often than not, there are blocks. And the blocks are me. And the blocks are, in each of the levels of care, there are, let's say, 10 suggestions as we step down. And I will remove 5 of them. Or all of them. And then by the time we get to the end, I'm not even in any levels of care. And I have fast-tracked. Instead of a 1-year continuum of care, in many cases, what we'll find is that the client will only, quote-unquote, be willing to do 28 days of rehab and nothing else. And so when I started this, I said that there are different things that we use to determine where people fit, right? Per the ASAM criteria, there are basically 6 dimensions, right, that they go over. And they score them, right? They go over these 6 different areas, and I'm just going to kind of generalize them for you so that you can kind of understand where people fit, right? And they score them on a 0 to 4, right? Highest level, lowest level. Where do you fit? And so the first is my withdrawal potential or my detox, right? If there's no detox, let's just say I knock on the door of a place and I'm a week sober and I'm but I don't think I want to go to rehab. I don't necessarily fit in that arena in a highest level 4.0 level of care, right? I just don't, But if there's a high acuity or a high danger, right? There's some seizure risk or high potential for high withdrawal. It's a 4, right? So I put a little 4 at the end of it. Second, are there biomedical complications, right? The second dimension that we look at, are there other medical factors, right, that are contributing to the situation going on? Bad back, diabetes, do I have stuff going on, right, that is affecting this, right? Here's a common one that a lot of times people will say. I have, let's say get an injury, right? I got in a car wreck, right? I'm showing up at rehab and a broken arm, right? Or I've got a bad back and I'm on opiates, right? So they have to take into consideration the biomedical complications, right? and how that can affect different levels of care. For example, we've had people that were exceptionally sick, right? Had brain injury, right? Traumatic brain injury and a fall risk. They were at risk of falling. They were really, really sick. And so, do they belong in like an outpatient, rolling on into outpatient? Some would argue no. Some would argue you maybe need to be in a place, right, that has doctors and nurses and that kind of thing, oversight to make sure that people are okay. The third dimension, if you will, is like emotional, psychological, behavioral complications, right? And so, for example, and I've mentioned in some other talks, I'm dually diagnosed, right, which means that I have underlying mood disorder in conjunction with my substance use disorder. And so the severity of my emotional dysregulation, right, or psychological stuff can absolutely change my level of care. If I were a schizophrenic, for example, not quite on my medications, they weren't right, and I'm hearing voices right now, I'm not going to do real well in an outpatient level of care, right? I need some stabilization. I need a higher level of care because there are some factors, right, that are complicating the other stuff, right? And now the fourth, and this is where things get interesting, right? The fourth dimension that we measure is the readiness of the individual to change. And here's where things are really kind of backwards. Things get backwards in the universe. In a perfect world, the highest my readiness to change, the lowest level of care I can start in. In other words, like if a client called me, an addict, and said, I'm 100% willing to do whatever it takes to get sober, 100%, and they meant it. And I don't mean like a transient 1 hour, I'm ready. I'm talking about the all in, and it stays. Believe it or not, they could benefit from just outpatient. Because in the outpatient would make other suggestions. Go to meetings, do this, get a therapist, do it, and they would do it. They were like, yeah, I'll do it, right? And so technically, outpatient exists for the highest readiness to change. However, what has happened historically throughout the country is the opposite can happen. And how can that possibly be? If there's these ASAM criteria and there's questions, is because addicts, those that are the least ready to change, have the lowest level of honesty, authenticity, vulnerability, accountability. They're unreliable narrators. And so, for example, let's say somebody shows up and they don't want to go to rehab, right? They don't want to go to residential. They just want to go, they're willing to do 2 days a week. And they don't really belong in, let's say, our program, an outpatient. And we ask them questions like, so have you lost time from work for drinking? I'm like, no, doesn't really affect my life, no. Any family issues? Yeah, my wife a little bit, but not really. I'm here because I want to be here. How much do you drink? I have a few, not more than any. It's been getting a little out of hand, maybe 2, 3 a day. Now, the answers really, if we were to ask the spouse, are way, way different, right? And so understand, he in the story, he's the patient. And so we have to go on that. I do want you to know that in many cases, those of us that have an outpatient, right, or work in an outpatient, we know in advance there's probably some inauthenticity. We also know that what is going to happen is they're in the wrong level of care, and within a month or so, within a week or so, they're either going to start failing the drug tests or not showing up, and we're going to have we recommend a higher level of care conversation. But what can happen a lot of times is they only agree to do that to get their loved one off their back, So readiness to change. The lower my readiness to change, the higher level of care. If I have no readiness to change, well, there's technically a level of care beyond a 4.0, which is jail. If I'm drinking and doing drugs and drinking and driving and I have zero willingness to change, and even rehab after rehab doesn't fix me, sooner or later what will happen is the legal system will take over and take away all my votes. And that would be the highest level of care, whether it's right or wrong. And so there we go. So the fourth dimension, if you will, is my readiness to change. The fifth is my relapse potential, my own ability to kind of stay sober on my own. Do I have a high relapse potential? Do I have the ability to stay sober on my own, right? So if I kind of can, right, it's just I need a little bit of extra help to get down to underlying issues, then I can navigate into outpatient. I can drive to outpatient. I can drive away from outpatient when I'm done, pass the bar, go to some support group meetings. I can kind of stay sober on my own. But if there's high relapse potential or actual, what will happen is we'll recommend the highest level of care, And so has there been attempts to stay sober, and have they been successful or never successful? And so the final is environmental factors. Like, are there factors that are negatively affecting my home life, right? My ability to stay sober. Am I in an abusive environment? Am I in a high drug using environment? Am I in any of that stuff? And that can require. In other words, if I'm in an extremely if I'm living with drug dealers right now and it's highly abusive and drug use is just running rampant, it's really going to be challenging for me to go to a outpatient 1 day a week or 2 days a week and then come back home. And so in a lot of cases, we have to step away from this environment. Otherwise, it'll just keep bringing us back down, right? And so those are the dimensions that we look at in terms of the ASAM criteria, and kind of like, how do you pick, right? How do you know which one is the one to go? My personal belief is that what is designed out after the residential is equally or more important than the first 28 days. Rehab would disagree with this. A lot of residentials would be like, no, we're the place. Like, we do everything here. We're going to fix your son, your loved one. Yes and no. In reality, where the system breaks down is when they leave treatment. The bridge back home. And in many cases, there is no level of care. They go just back home and they do 90% of what they did before, which is nothing towards their recovery, except for I'm just not going to drink. And then what will happen is sooner or later they'll dysregulate. Sooner or later the anxiety will go up. Sooner or later the triggers. They're no longer in this. And then what will happen is life will throw them a blow and they'll drink. And then everybody will be up in arms, drink or drugs. And we're like, oh, let's put them back in rehab, back in residential. We'll weaponize because we don't really understand how it works. So I will say, if you're kind of stuck in this trap, I'll put them in rehab. Oh, you relapse. Oh, put them in rehab. Oh, put them, and back and forth. Home, rehab, home, rehab. You're probably not missing the right residential rehab. What you're missing is the 3 months after. And usually what will happen is, if we were to judge, look at that, you'll discover that it rapidly diminishes to zero. Because the client themselves takes over the steering wheel right away. And so hopefully I've been able to break down a little bit of levels of care, different types of rehab, where people fit. In a perfect world, we're collaborating with you at every step of the way. I will say that from my personal experience, and one thing that we suggest for families, and one thing that eventually the addict will have to do, is that what I had to do is that I had to be willing to fire myself as the sole decision maker and designer of my treatment planning. And it's interesting that I, as a patient with an hour of sobriety, would argue with professionals, addiction experts, doctors, therapists, counselors, psychiatrists, how I know more than you and how your solutions won't work for me, and let me instead counter with mine. And I will say, in a lot of cases, when I look at where the system breaks down, it's almost always because the patient is now sitting in the seat of the designer of their own treatment plan. And their design is always based on comfort and not success. And so what our job is to counter with the highest possible success and, at times, discomfort. So hopefully I've been able to understand a bit of that, or explain a bit of that. And thank you very much. And this was treatment, outpatient, inpatient, and levels of care. Okay, thank you.